Thank you. Well, hello. It's really nice to be here. It's been a bit of a rush. I just landed at 5 o'clock and negotiated the traffic going through Dublin in and out. So, yeah, but it's good. So, I had to correct one thing. I am not a psychiatrist. I'm a psychologist. So, yeah, no, it's fine. I don't prescribe meds and I can't answer questions about meds and that kind of stuff. So I work psychologically with young people, adolescents and adults. So Fiona asked me to talk to you about ADHD and substance use disorder. And I was very happy to do that. I have a talk. But actually, at the time when we were sort of setting this up, I had a client, myself, a mother, and who was very concerned about her son, and it brought up loads of issues, and she actually had a dilemma that she had to consider. And I thought, well, this would be just great, because I know that you're parents, and it would be really nice to hear about, you know, a real live situation. So I did a sort of brief synopsis of it, and I thought, you know, I'm going to hand that out to you in the break and have a chat and see what you would have done, what you think you might, you know, what given her options that was given to her by the school. So, you know, so we'll talk about that a bit later on. So these are my disclosures. So many people will think substance use, well, not my child, not, you know, that my child won't do that. But, you know, the fact is that many of them do. And I think particularly those perhaps that are, those that haven't been diagnosed yet. And perhaps, you know, they find it reinforcing and they're seeking drugs as a way of self-medicating because they help them in some way. But there have been some studies, most have been done in the US, and I'm going to mention a few times to you about meta-analysis. And that's just a sort of fancy word for it when researchers take all the studies that have ever been done that meet a certain criteria, that they're good, robust studies, and put all the data together and reanalyze it all. So instead of having small samples, a few studies with small samples that perhaps are showing different results, they put all of these samples together and reanalyze the data so it's much more powerful and it gives a real good indication of outcome. So one here that was published in Drug and Alcohol Dependence was put together 29 studies of people who were seeking treatment for substance use disorder. So they're not people with diagnosis of ADHD, and they were seeking treatment. And this together with the samples they put together, there was over 6,500 cases of people in there. And when they looked at this and looked at how many had been diagnosed or recognized to have ADHD, nearly 1/4 of them, of young people and adults who are presenting at services for that reason, had a diagnosis of ADHD. 1/4. And then if you look at it the other way round, if you look at how much substance use there is in young people who have a diagnosis of ADHD in the ADHD services, there have been studies that have looked at that. And in fact, nearly heading towards 2/3, up to 58% of adults with ADHD will have coexisting substance use disorder. And those individuals, those with ADHD, will have an earlier onset of using substance misuse and a more severe history of using substances. So they're more complex and it's more difficult, and that, you know, that it's a greater problem for young people with and adults with ADHD compared to people who are misusing substances who don't have ADHD. And again, a meta-analysis, this time of 27 studies that followed up children into young adulthood who were, you know, towards the end of their teenage years, about 19 years, mostly male. They looked at over 4,000 young people with ADHD, and they compared them to nearly 7,000 people without ADHD. And they looked at their use and what they were using. And what they found is that those young people with ADHD, compared to those who didn't have ADHD, had nearly twice the risk of abusing alcohol. And they had nearly 3 times the risk, increased risk, of using cannabis. And just over 2.5 times the risk of using other drugs. I mean, that's quite a lot. And so what that means, and what I see is, you know, the sort of not my child kind of thing, that starts to wither away with ADHD children as they go into their teenage years. A study that my colleague Gisdike Johnson did in Iceland, actually, it was an Icelandic study, in the community, and they went in Iceland. They had the ability in Iceland to go in and into schools and get data on almost every child in the school within a certain age group. And they go in and they do these huge surveys. And they had this study of over 11,000 14 to 16-year-olds who are at school. And they gave these groups questionnaires that showed the level of symptoms with ADHD, whether they were kind of symptomatic for ADHD or not. And they sort of divided these groups this way. And what they found was that smoking, use of alcohol, and illicit substance use, all of them, were significantly associated with ADHD symptoms. And that was with a large effect size. So what that means, it was a very big, powerful finding. The distinguishing substances were LSD, cocaine, mushrooms, and amphetamines. I was really surprised when I saw that, not to see cannabis in there. And I think because everything else, all the other studies are pulling out cannabis use. And we know clinically that this seems to be one of the biggest, the sort of route in, I think, for young people is to use cannabis. And it's quite a big problem for teenagers and adults. I don't know what to make of that, other than to think maybe, you know, any moment in time when you do a study, of course, what young people are using will depend on what's available. So maybe there was a moment in time when there'd been a big crackdown on cannabis. I don't know, but they were certainly accessing other drugs. But these were the substances that stood out. And particularly interestingly, the use of amphetamines, which kind of gives a bit of a ping in your head that says, well, maybe these kids are attempting to self-medicate, because we were dividing them into symptoms of ADHD. We weren't dividing them by whether they had a diagnosis or not of ADHD. This is based on whether they were self-reporting symptoms of ADHD. Now, there was is there a pointer? No, don't worry. So this slide, doesn't matter that you probably can't see it that well, because these are all the different drugs. Like cannabis is here, hashish, substances, amphetamines, mushrooms, coke, ecstasy, LSD. But and what you can see is this dark one is the symptomatic group, and the light one is the non-symptomatic group. So you can see that this just visually, it's telling you there's a very big difference and a very big problem. Don't worry, Fiona.
Stop.
Fiona, don't worry. Yeah, no, I'm now multitasking up here, negotiating an open door as well. Thank you for trying to find it. Okay. And again, this is the same study, and the symptoms, those kids who were rating high rates of ADHD symptoms, that was predicting smoking, alcohol, and illicit drug use, but also beyond what comorbid problems, so beyond them self-rating problems associated with anxiety, depression, or sort of conduct type problems, being anti-establishment. So it wasn't just related, in other words, to their anxiety and depression, it was related to the ADHD, okay, because it was beyond those other comorbid problems. And polysubstance use, using lots of different substances, was incrementally related to ADHD, especially for girls. So girls were much more likely to start like spreading out and trying other substances and using different substances, more so than boys. So what are the gender, are there differences as to whether you have a boy or a girl? And actually, I'm going to tell you that there are some differences, but there might be significant differences, but the boys are still way up there, you'll see in the graph. So don't mistake the fact that I'm saying it's all females, because it's not, okay? And you'll see that. But there was a massive study done in Denmark, and you know, in Denmark, they have these registries from the moment you're born, that, you know, they have all this data on everybody, where you're in prison, your medical records, your prison records, your health, loads of school academic records. They have all these records on everyone that over many years. And they looked at these these nationwide registers of children born between 1990 and 2003. And this was like, you know, 729,000 young people, kids. Just over 19,500 of them had ADHD, and they were specifically, Søren Dalsgaard in Denmark, he was specifically looking at the gender differences. He wanted to know, he was asking, are there differences in their comorbidity, in the kind of difficulties they have alongside ADHD. So they weren't just looking at substance use, they were looking at lots of other things as well. And what he found was that if you have ADHD, this increases your risk of alcohol use, of using cannabis. Cannabis particularly came up here, and other drug use. So in other words, it increases your risk for everything in terms of substances. But it increased that risk, not just for those who had who had other problems like anxiety and depression. It increased the risk for people without those comorbidities as well. So it's not just about young people who are complex in their presentation, who've got ADHD, who perhaps suffer with depression, anxiety, low mood, who are emotionally volatile. Perhaps so. It's not just that group. It's also the group who have kind of the standalone ADHD. Not that we see that very often, but they were also at increased risk. Some problems even further increased that risk, though, made it much, much worse. And that was if you've got conduct disorder, depressive disorders, bipolar or schizophrenia. Generally, though, there were very few gender differences. They weren't that different, although females did have a higher risk of some substances than males. And that was, in particular for females, the marker was alcohol and cannabis. And that's something you tend to hear, and I tend to hear a lot, and I just see that a lot with females. I've just done a female consensus, an expert consensus, and I presented the headlines from it yesterday, all about females with ADHD. And clinically, that's something that we're seeing an awful lot with the females with, you know, marked severe use of alcohol and cannabis. Not to say the boys aren't doing that, they are, but it's probably more prevalent and more marked in the girls. So this is just just showing you that the males are blue and the females, and this lower one, this is the ADHD boys, these are the ADHD, non-ADHD boys. So you can see with the alcohol use, cannabis, you see the really big differences, aren't there, here. And the same with the females here. These are the females with ADHD, females without. You can see here with the alcohol how much higher that is. This is cannabis, and this is other illicit drugs. Why? So how do we explain this? What's sort of going on? Well, there are various theories in the ADHD world as to why this could be. And there's 4 classic theories. One is that the self-medication hypothesis, that young people are using drugs to alleviate their symptoms and associated impairments. Psychostimulants affect the dopamine, and therefore that impacts on their symptoms. Second one is the behavioural disinhibition hypothesis, and this hypothesis is that it's all about having a desire to seek novel sensation-seeking behaviours, and drugs are seen as something that might kind of facilitate that. The third one is called the comorbidity hypothesis, which says, well, actually, this is nothing to do with ADHD on its own. This is all associated with the comorbid, the coexisting problems like anxiety and depression. All right? And that kind of, as well, pulls together some of the self-medication hypothesis and the behavioural disinhibition. It kind of pulls aspects of that together. And you'll remember, I just said to you in one of those studies that that it was found that ADHD was elevated risk in young people with ADHD if they had comorbid problems, but then they looked if they didn't have the comorbid problems and the risk was still there. So that kind of argues against the comorbidity hypothesis. And then the final one is the sensitization hypothesis, which basically hypothesized that early use of stimulant medication, it alters the dopaminergic system. So it alters how the brain is working, and it makes illicit substances more enjoyable. So that kind of argues that if we put our young kids on stimulant medication, then we might be sensitizing them to be setting them up to take drugs when they grow up. Well, when you look at the data for these, well, if you actually look at what the data is telling us, in terms of self-medication, the self-medication hypothesis, well, you know, whoever you talk to, whatever doctors you talk to, everyone sees it because we see it clinically so much. And it's very plausible. And we know that those with more ADHD symptoms use more drugs than those without ADHD. So, you know, it's plausible. But we had to actually put a question mark in here when we looked at the data about this, because there isn't really good studies that test this hypothesis out. And yet it's something, you put a whole load of experts in a room, it's something that they'll all agree and they're all sort of talking about, and because we see it, you know, and I can see some of you are nodding, you know what I'm talking about, you're seeing it as well. So with the behavioural inhibition, that's having a disposition to novel sensation-seeking behaviours, if you look at testing those kind of things formally with, you know, neuropsychological tests, putting them in a room and getting them to do things and testing them, there's little evidence from that about behavioural inhibition that being related to their use of substances. But there is some evidence that it might be associated with novel sensation-seeking behaviours from a personality perspective. So people who have a personality, perhaps, to be sensation-seeking individuals, to be the get up and go and let's try things out and let's, you know, get out there. Those are the individuals who might be more likely to start taking drugs. The comorbidity hypothesis, there is some evidence for that because there are high rates, as I just said, of comorbid externalizing and internalizing disorders among people with both ADHD and substance use. And this is potentially also associated with novelty seeking and self-medication. The one that has been not kicked to touch, there's a lot of evidence with this. There's a wealth of evidence to contradict the very unhelpful hypothesis that if we're giving our kids stimulant medication, we're going to turn them into drug addicts, you know, like the popular press might say. And in fact, if you look at the evidence is the other way round, that actually if you get these kids and you give them treatment, that it has a protective, positive effect on them. So it actually protects them from becoming engaged in drugs. They're less likely to do that. Haven't got time to show it to you today, but I've actually got a lovely video of a young man who kind of describes how he would be using kind of quite a lot of cannabis and he'd be doing that. But when he went on to medication, he didn't feel that he needed to take these drugs anymore. Just felt, you know, just didn't need it. He stopped. Probably because he was self-medicating. So what in answer to why, it's probably a mixture of some of these things, the self-medication, behavioural inhibition, and comorbidity. What can we learn from a subgroup of people with very high rates of substance use disorder, of offenders? And I've done a lot of work with offenders with ADHD, working in the criminal justice system, and done a lot of research. And I did a meta-analysis looking at all the prison data internationally that we had, and looking at how many people have got, what's the rate of people in our prisons that have ADHD. And what we found is if in the adult prisons, it's 26%, like just over a quarter. And in the youth offending prisons, it's about 30%. So, you know, it's quite high. There was no difference whether you were male or female. And actually, those differences between the adult and youth was not statistically different. And that may be, though, because different countries have different ages. They classify youth offending institutions by different ages. So there might be a little bit of a muddying of the waters between the two in terms of age. But the bottom line is around 1/4 of people, maybe more, have got ADHD who are involved in the criminal justice system in some way. We looked at the comorbid problems that these individuals had. We did a meta-analysis of this and looking at over about 1,615 ADHD cases and comparing them to 3,128 controls. And we looked at presence of conduct disorders, substance use disorder, mood disorders, anxiety disorder, and personality disorder. And generally across the rates, if you've got, generally in the prisons, around 70% of people in the prisons are taking drugs, have got a history of misusing substances. And that's about the same whether they're youths or adults, because they've got a history of it. These pale blue ones are prisoners without ADHD, and the dark blue ones are prisoners with ADHD. Okay? The ones on the left are the youth, the ones on the right are the adults. And what this is telling you that with the youths, pretty much the same, whether you've got ADHD or not, with the exception of a mood disorder. Much more likely to have a mood disorder. But by the time they get into adult prisons, they've got significantly more of everything, significantly greater rates of comorbidity. So they're much more complex and including significant. So actually, you see this is higher in the youths, but it's not significant. It's not. It's high. It is a bit higher, but it's not a big enough concern. Well, I think substance use should always be a concern, but it's not significant. It's a statistical term that's used to look at how much we need to pay attention to something. But in adulthood, it is. So one of the problems is that we, the researchers, are going into these places and diagnosing ADHD. They're not the one of all the research that I've done in the prisons. It's us, the researchers, who are going in and diagnosing ADHD. They haven't got a diagnosis of ADHD already, and that's shocking because these young people are not suddenly waking up suddenly with ADHD, and like they've got a whole history. They've been missed in their education, by education psychology, by healthcare providers. They've absolutely been missed by lots of people at some, on their pathway. And it's been signposted very clearly, this person is heading towards real big trouble. And by the way, it's looking like they have ADHD. It's being missed. And one of the things is that it's not just about identifying this group, but it's also about treating them. And one of the big things, the concern with offenders with ADHD, is that people are worried about giving them medication because it's for ADHD, because it's a controlled substance, etc., etc. So we thought, well, if we do a study into this to look at their pathway into using medication, and we had to do it in the offenders because there's so many of them that are using it. It was a really good sample to do this in. And I think it generalises actually to people who are not offenders as well, to some extent. But we're looking at the pathway into using substances, and we wanted to know, and to do that, we had to actually generate a questionnaire. We had to make up a questionnaire, working with experts in the field. And this questionnaire asked questions about what was your motivation for using your first drug that you ever used? What was the reason for maintaining it? What was your reasoning? What was your reason for then starting to use another drug, moving on? And what was your reason for maintaining that? And so when we analysed all the data, And what we found is if we look at just all the substance users in prison, irrespective of anything else that they might have, just the substance users, well, there was nothing that predicted why, particularly why they first started, but they maintained because of sensation-seeking reasons. You know, so maybe they're the sort of novel kind of sensation-seeking group, and perhaps they started to develop a dependency. They moved on to another drug, again for sensation seeking. So, you know, this category, this theory 2, is starting to fit with this group. And they continued, though, to sensation seek, but also because drugs they started accepting that drugs was a way and part of their life. So then we analysed the data a different way. We pulled out everyone who's got a history of conduct disorder, of behavioural problems. It's very, this is an all-male sample, by the way. And again, this time the conduct disorder group started for sensation seeking. They began to accept and maintain. Then they moved on. Nothing really predicted why they moved on. But then they maintained at that stage because they were using it to cope, and they were using it and they were becoming dependent. But so with these two groups, you've got acceptance and dependency and sensation seeking. You've got some similarities here. When we looked at the ADHD group, wow, they took the first group, the first time they started drugs, they did it to cope. They did it to cope with difficulties in their lives, with problems. They maintained to cope. They started another drug to cope, and then became dependent. And they maintained to cope. It was just coping. We wanted to call this self-medication, but the reviewers of the paper that we wrote wouldn't let us because they said they wouldn't let us because they said we don't know they're self-medicating. Fair enough, but we think that was what was going on. So, what do we do about treatment? So we've got this group, we've got high prevalence rates, they're starting early on, they're taking a lot of everything and they're taking it to cope. What do you do? So I did a systematic review of long-term outcomes, and with treatment we found that some outcomes benefit more than others. So with treatment, any treatment, this is percentage of outcomes. So driving, obesity, self-esteem, social functioning, and academic outcomes, they're not so bad. Then you get to drug and addictive outcomes, not quite so good, getting harder. Antisocial outcomes, service use as an outcome, and occupational outcomes were quite fairly bleak. So we need to figure out how we're going to treat these young people with ADHD and substance use disorder. In fact, though, I said this earlier, there's little evidence that there's an increased risk of it as a result of treatment with stimulant medication. It's protective, and I've told you that earlier. The psychological treatments and NICE guidelines tell us what to do with people who have a substance use disorder. They tell us, and they recommend that, various incentive programs and couples therapy and CBT. They strongly put in there psychological treatments. They suggest group versus individual interventions. But of course, if you've got someone with ADHD, then you need to make accommodations for that person. You need to adapt the therapy to make it work better for them, perhaps having more frequent sessions, for example, and reminders to come to the appointment. So, this is a book that I wrote about ADHD for adolescents and adults, and this some of what I'm going to talk about briefly is contained in that book. If anyone's interested, it's written for healthcare professionals, but what I find is a lot of my clients and patients get it and read it anyway because it's full of strategies and they find it very accessible and they find it very helpful. So the first thing we need to do when you've got a young person with ADHD, what do we do with them? It shouldn't be a secret behind a closed door. Well, the first thing we would do is assess the nature and extent of the difficulties. We need to know the pathway to the use of that substance. Why did they start? What's going on there? We need to know why they're maintaining, the reason they switch, What are their beliefs about treatment? And what are the potential obstacles to them achieving, to them getting some control over the use of whatever, the alcohol or cannabis or whatever it is that is their drug of choice. And then you identify and you set goals of treatment. By the way, that book, and this is all in my co-author was Jessica Bramham, who's here in Ireland. I don't know if any of you know her. So, psychoeducation is really important. I've been treating a girl and she suddenly emitted, like, dropped a bomb in the therapy and told me that she's using a lot more cannabis than she told me. And in the therapy I had to do a complete about turn and start to use some of these techniques with her, and I had to kind of switch the goals of treatment. And she found this really helpful to think about what stage she was at, because you start at an experimental stage when you're curious, and then you might move on to a social stage which is influenced by the peer group. You know, everyone's doing it on a Saturday night at a party. Then there's an instrumental stage where you're purposefully taking the drug to seek a high or to cope with stress or to cope with negative feelings. Then there's a habitual stage when the need for use becomes more regular, it's more frequent. And then you move into dependency. And as we go through this, we acknowledge and relate these stages to the negative impact of substance misuse that it has on their life. So where they are, so how did this, when you're in the social stage, how did that negatively impact on you, on your life? What was going on? So you might be thinking about things like maybe they've been verbally or physically aggressive, and that's associated with a stage, or they've been paranoid, or they've engaged in unsafe sex, or anxious. So all, you're relating it to things, their functional experiences. And then we engage in something called motivational interviewing. Do any of you know what I mean by motivational interviewing? The process of change is a journey. And as I go through this, just think to yourselves, I'm not going to ask you, how many people have ever been on a diet? And how many diets have we been on? And how well have we sustained our diet and achieved it, and when it collapses and what have you? And it's a journey. Or how many of us have been through this stage when we've given up smoking? It's tough, it's hard. And there's a thing called this model of change, the trans-theoretical model of change, and just think to yourself as I do this about your stage with your diet or smoking, whatever. Stage one is a pre-contemplation stage, where we're sort of half considering it. Yeah, it might be a good idea, you can do it and I'll watch and see how you get on. Then stage two is a serious contemplative stage. Yeah, I'm really going to think, I really need to think, maybe there's a Weight Watchers nearby, or, I think I'll do it next week, right? 3 is a determination stage. Yeah, I'm definitely going to do this. I can't, these scales are upsetting me just being there. They're screaming at me every time they're in the bathroom. I don't want to open the fridge door. Things like, and this is the same with the drugs. It's about pre-contemplative stage, contemplative stage, determination stage. Then you take action. You join Weight Watchers, or you go out and buy some patches, or get an e-cigarette or whatever. But you take action, and then they take action, they start to do things. And then you have to go through a maintenance stage, because you've got to maintain. And the pathway is not linear. So how many times in your diet or smoking have you sort of fallen off and gone back to contemplation? Now, I remember when I was smoking, I can remember getting patches. And I remember I'd take off the patches and have a cigarette and put the patch back on. So that's going back, I'm relapsing, and I'm going, so you oscillate between this. It's not a linear, it's not nice and neat. Okay, so what you need to do is you identify positive and negative support networks. We identify goals and steps. You've got all these things written out in your handouts. Might do a dissonance chart. I find that this is very helpful. That's the difference between the current situation and the future goal. Where are you now, and where do you want to be? And then what do we need to do to get you from here to there? And the other thing is, then you can assess how realistic it is where they want to be. Actually, and I'm also treating a young girl, a 17-year-old at the moment, and I'm using some of these techniques because she's got an eating disorder. And I did this recently, that where you are and where you want to be, and what to check that she wants to be a correct weight and think, so. And this is a kid with ADHD. Then you might do a decisional balance matrix. You think about what's the positive and negative of using the substance, positive and negative of going on a diet, giving up smoking. Then there's CBT. Then we go into the harder treatment. So you motivated them to do it, and then when they're all fired up and they understand they've got all the psychoeducation, you've got to start whacking things in. They need skills to avoid risky situations, to avoid places or parties where the drugs might be, to avoid walking. There was a place in West Croydon where I worked for many years in the community, and we'd be trying to treat these people, and they'd say they were walking back to West Croydon station, and it was called the cannabis walk, because you walked and you could smell it all the way along the road, and it was like terrible. And I remember trying to figure out, with one they had to go to a different station and things like that. Assertiveness training. Sometimes people need to learn how to say no appropriately, okay, to learn, and that means role play. They need to control their physical cravings and urges because it's physical. So that means distraction techniques, compensatory strategies. Okay, so I had one person with alcohol with beer, and when he wanted a beer, we switched it to lemonade. He said a lemonade might do it because of the fizzy thing, so he'd get the drink. Dysfunctional beliefs. You need to challenge negative thinking and beliefs. So, they're taking it to cope. Cope with what? You've got to work with that. And identify whether they're what we call thinking errors, whether they're catastrophizing. If I don't have a spliff every night, the whole world's going to come to an end. I'm not going to be able to work. I'm not going to be able to, no one will like me. And then, of course, activity scheduling. Activity is very important to get them outside and healthy. You build self-efficacy and give a sense of empowerment. They need to develop positive social networks. Check who's around them, who they go to, whether they need to seek different mentors or buddies. Give them reward techniques, and actually it's so important, because I'm not always going to be there to put in rewards and remind them. So my role is to get them to learn to self-reward, and not self-reward with I've managed not to have a spliff all week, so Saturday night I'm going to have one. But they've got to find a different way to self-reward, and you need to address the comorbid problems. Expect relapse. That's going to happen. That's in the model, to expect it. So forewarned is forearmed. You have a plan of action for relapse. I give them a notebook, and I have strategies, and I get them to write stuff in the notebook, how to access help and support, to give themselves words of comfort and reassurance. Because when they relapse, they're feeling overwhelmed, distressed, and they're high again. Then they're upset with themselves because they've taken a step back, and they're feeling like, really fed up with everything. They won't remember all the things that you've told them, right? It's all gone off into the abyss somewhere. So I want them to remember one thing: get your book. I get them to write everything in a book, and they have to write it themselves in their own writing. They have to own it. So write things down, and they get their book, and then what they're going to read is what. So I'm relapsing. Don't worry, it's okay. It's part of the model. I just take a step back and start again, because it's a journey, and I'm still walking the path. Things like that. So we're going to